Okay, so the presentation today will be on blood flow restriction and a scoping review of the current literature as of 2018. The objectives that we will cover will be blood flow restriction definition and what that actually means, the effectiveness of BFR, local and systemic physiology, the mechanisms of BFR, the safety and side effects, as well as the practical and clinical applications. Definition. So blood flow restriction is training that entails applying a tourniquet style cuff on the proximal aspect of a limb just prior to exercise. The cuff is manually tightened or can also be pneumatically inflated to a pressure that occludes the venous flow yet allows for arterial inflow, and the pressures are usually, as you'll see, are calculated as a percentage of the amount of arterial inflow that is allowed. It was originally conceived in the 1960s by a gentleman named Sato in Japan. It was termed Katsu training and has been quite prevalent in Japan ever since. Prior to 2008, however, the BFR training equipment was scarce outside of Japan. It has recently made its way over to the United States in the Western Hemisphere and has grown rapidly within the literature. Thus far, the research results regarding the efficiency of BFR have been consistent and promising. All right, so let us get into the effectiveness of BFR. Okay, exercise and blood flow restriction lead to hypertrophic adaptations within the muscle at much lower intensities than previously and traditionally thought. The cutoff is usually about 65% of 1 rep max. As we will see, is that you need significantly less intensity than that in order to get the hypertrophic adaptations and changes. A low-intensity BFR has been shown to be equivalent to the moderate to high-intensity hypertrophy. It is not clear, however, if muscle hypertrophy can be optimized by BFR plus an increase in external loads, or if the ceiling for maximal hypertrophy is achieved with low to moderate loads. And we'll discuss this further as we get into the practical applications in slides to come. Okay, so the effectiveness of BFR in muscle adaptations, I think it's helpful to start off with a large meta-analysis that kind of gives us an overview as to what the literature has recently said. This was published by Jeremy Lenicky and colleagues. He's out of the University of Oklahoma. This meta-analysis in 2012 included 11 studies. Okay, here in Table 1 we can kind of look at the populations that were looked at within the included studies. So the age, they were relatively young with the exception of 2 studies. Their gender was predominantly male. The activity status was recreational and or athletic based with the exception of the bottom 2 studies there. All the exercise modes were for the lower extremities. None included the upper extremities here. So here we can kind of get a sense of the exercises that were used as well as the intensity. So if we highlight the intensity, again, some of these studies are not only resistance-based but also aerobically based exercises. So the strength-based exercises range from 20% to 30% 1RM, whereas the aerobic studies were also within a relative ballpark of one another. When you're looking at the pace of walking and or cycling, you can see 50 meters per minute. And then up to 67 meters per minute. Frequency of training was kind of all over the place. You had everything from 2 times a week up to 14 times a week. Same with the length of training. There was a variety of durations of studies from 2 weeks all the way up to 10. And then when you're looking at the measurement of hypertrophy, majority studies use the MRI, and then 2 studies use the ultrasound. The conclusions that the authors drew from the meta-analysis was that BFR resulted in a significantly greater gain in strength and hypertrophy when performed with resistance training versus the aerobic exercise such as the walking and or cycling. The low intensity BFR 2 to 3 times per week provided greatest effect size compared to the 4 to 5 days per week, and this was there were significant correlations that were found between the effect size for strength development and weeks of duration, but not so much for the muscle hypertrophy. Okay, another nice conclusion that was made by the meta-analysis was this diagram that kind of helped individuals visualize the timing of adaptations from when you're comparing and contrasting low intensity BFR to traditional resistance training. It's a relatively busy diagram to look at all at once, so we'll kind of step through it here piece by piece. First, on the y-axis, you have the progress or the amount of adaptation for hypertrophy, strength, and or neural. Across the x-axis, you have time, which is self-explanatory as far as the duration and onset of such adaptations. So the red lines here are going to represent the low-intensity BFR, where the traditional resistance training are going to be highlighted in light blue. So if we first look at hypertrophy, we can see that the hypertrophy is quicker to come on when performing low intensity blood flow restriction versus like the traditional hypertrophy of resistance training will actually be a little bit more delayed in its onset, but over time will supersede that of the low intensity BFR. Strength. So strength wins out with the traditional resistance training. It comes on earlier and it supersedes the strength that is gained by the low intensity BFR over time as well. When we're looking at the neural adaptations, a little bit of a different story here. So yes, it occurs first with the traditional resistance training. However, over time, the adaptations of the nervous system are greater with the low intensity BFR. And so again, when you're considering the strength, the hypertrophy, the neural adaptations, it's and what would be implicated or best indicated for the patients and or athletes or clients that you work with, this will give you a theoretical model to be able to better predict the adaptations that they will undergo, whether they're using the BFR or the traditional resistance training or a combination of the two. So here's another nice diagram laid out by this meta-analysis. You can see on the y-axis is the effect size, on the x-axis are the weeks or the duration of the exercise training. The green line there represents strength, and that's pretty consistent throughout the training, regardless of the weeks or the time of the low intensity BFR. However, the hypertrophy is obviously a different story. You can see that really after 6 to 8 weeks that the hypertrophy really starts to take off and make greater gains. So this was a second and more recent meta-analysis that was conducted. You can see the two forest plots here. This was published in 2016. There was 28 studies included within the meta-analysis. On the left-hand side of the screen, you have the muscle strength. And you can see that the negative values of the forest plot represent the control, where the positive ones represent the low intensity blood flow restriction. Again, the majority of these studies are showing the effect favoring the low intensity BFR for muscle strength. And then if you turn your attention to the right hand portion of the screen, you can see that there's a relatively similar story there for the hypertrophy as well. And then the diamond down at the bottom of each diagram can provide more of a guidance as far as like the aggregate effect size that was shown, and the low intensity BFR again is favored in both diagrams for muscle strength as well as muscle hypertrophy. This meta-analysis also included a cardiovascular component. If we transition here, you can see that that these studies are those that are done for aerobic blood flow restriction. So same setup, right? So the negative values are the controls, whereas the positive values are favoring the low intensity BFR. For muscle strength and hypertrophy within aerobically trained individuals or subjects. Again, the BFR is favored throughout, though the effect size is slightly less than what we saw within the resistance training articles in the previous slide. So the last couple slides have given us a larger picture of the effectiveness of blood flow restriction for individuals who are resistance training, as well as those who are aerobically training in the presence of blood flow restriction. And it gives us an idea that yes, it's positive for strength and hypertrophy, as well as neural adaptations, and that those effects are kind of augmented in the presence of resistance training. I also want to kind of highlight a couple studies that had really kind of caught my attention as I was going through the literature and trying to identify or get a sense of what blood flow restriction benefits can actually have for certain populations. So the next couple of slides will focus on some of those studies. So strength and blood flow will be first, blood flow in surgical populations, and then the BFR in neurological diseases, as well as BFR in muscular diseases. So this study here included 16 females. It was they focused on unilateral plantar flexion or heel raises. The cohorts that were included were 25% and 50% 1RM. The individual's opposite limbs served as the control. So one of the calves had blood flow restriction while the other calf did not. Both calves went through the same exercise routine, right? So the duration was 4 weeks, 3 times per week, 5 to 8 minutes per set, and there was 3 sets of as many as they could do to failure of heel raises on one leg and then the opposite. The cadence was standardized 1.5 seconds up and 1.5 seconds down. The outcomes pre and post were isokinetic dynamometer testing, which utilized strength of their 1RM, the isometric max volitional contraction, as well as torque or power at different standardized speeds. They also looked at the blood flow within the calves pre and post. Okay, here you kind of have some of the results, right? So this is change in 1RM. You can note that the change in 1RM is in kilograms on the y-axis, whereas on the x-axis are the training groups and the different cohorts, right? So those who trained at 25% of their 1 rep max and those who trained at 50% of their 1 rep max. And there was a significant difference in both cohorts, regardless of the intensity that they were training at, of the BFR versus the non-blood flow restricted calf. An average of 26% 1RM was Okay, so here in this slide we can start to look at some of the results from the study. On the y-axis you have the change in 1RM in kilograms. On the x-axis are the training groups, those who were training at 25% 1RM and those who were training at 50% 1RM. The black represents the calves that did not have BFR, and the white represents the restricted calves. You can see that by noted the asterisks above both of the white rectangles or bar graphs there, that this is a significant difference from the opposite limb. And on average, regardless of the cohort, there was a 26% increase in the individual's 1RM within 4 weeks. Okay, here in this slide, you're looking at the isometric max volitional contraction that the individuals could produce with a single calf, again measured by the isokinetic dynamometer. On the y-axis, you have Newton meters. On the x-axis, you have the different training groups at 25% 1RM and the 50% 1RM. Again, the asterisks above the white bar graphs denote a statistically significant difference from the non-BFR trained limb, and this was significant. Again, there was a 106% increase across the limbs that were trained with blood flow restriction, again within only a relatively short time frame for strength gains within 4 weeks. All right, here you're looking at the blood flow change pre and post between the BFR calf and the non-BFR calf. So for the individuals with 25% 1RM and the others who trained at 50%, you can see that there's a stark difference and certainly a statistical significant difference between their BFR trained calf and the non-BFR trained calf. And there was an increase on average of 43% with the blood flow, which is again pretty incredible, only within 4 weeks time frame. Okay, so obviously in the healthy individuals shown in that last study, that there's certainly effect with the hypertrophy as well as the strength gains and the blood flow within a relatively short time frame. So let us turn our attention now to the post-operative patient demographic. Specifically here in this study is the knee arthroscopy. I want to orient you to the table there on the left side of the screen. So you have the method variable, the subjects. There was 20 of them, 10 of them allocated to a BFR and 10 of them allocated to a control cohort. The duration was 12 sessions for 6 weeks, approximately 2 sessions per week. And then the type of exercise, so the controls did the post-operative protocol. The BFR group did the same, with the exception that they added in a leg press, leg extension, and kickback, like a kind of a donkey kick or a kickback on a machine. The machine was a shuttle press. The volume and intensity of the BFR, so there was 4 sets that were performed, 30, 15, 15, and 15. This is a traditional set and rep scheme that is used within the blood flow restricted training, and we can talk more about that as we get into the clinical applications later on. Here's 30% 1RM. The sets, like the rest between each of the sets was 30 seconds, and the exercise rest between each of the leg press, leg extension, and kickbacks were 1 minute. So if we're looking here at the thigh girth, or the amount of hypertrophy proximal to superior patellar pole, we can see that 6 centimeters proximal for the occluded group was statistically significant. You can see the p-value there. And then the 16 centimeters proximal, again for the occlusion group, the p-value is well below the 0.05, whereas the control group had no statistical significance pre and post at either of those locations on the thigh. Okay, so here are further results from that same study. They looked at the peak torque of knee extension and knee flexion relative to the individual's body weight in kilograms. So the knee extension, we can see that the occluded group had a 23% quad deficit, at least from their torque strength, relative to their non-involved limb. The standard group, however, had a significantly higher deficit at 42% relative to the non-involved or non-surgical limb. If we're looking at the percent improvement over time, within that, again, it was a 6-week time frame. There was a 75% increase in the quad torque. And then if you're looking at knee flexion, it was a similar story here. The one thing that is interesting is that the occlusion group actually surpassed the knee flexion torque of their non-surgical limb within that 6-week time frame, which is pretty surprising and incredible. This was explained by the authors due to the fact that the quadricep muscle was more affected, in the sense that it was one, because of the surgery on the knee and the inhibition of the quadricep that takes place post-operatively with the knee effusion, but then also the fact that the quadricep was an anti-gravity muscle and can be more affected with immobilization. But again, if you're looking at the percent improvement, again, it kind of shows that the occlusion group significantly outdid that of the standard or the control group with 40% improvement. Okay, so we looked at the objective findings and results of this study. Let's kind of take a look at how the subjects perceive their abilities following the surgery and following the intervention. So the BFR group was statistically significant improvement in all subjective outcome measures. The things that differed, right? So if you're looking at the control group, they did not improve in their COOS symptom, their ADL, or quality of life from the time immediately following surgery to that 6 weeks after surgery and after the interventions and rehab. Also, the one functional or physical outcome that was still a deficit with the control group was their stair climbing ability. Okay, here is another postoperative study that was done specifically for ACL. You can see that the subjects, it was a relatively small study, 16 subjects, 8 allocated to BFR, 8 allocated to a control group. The males and females split evenly, 8 and 8, with average age of 23 years old. The duration, it was for 2 weeks, from day 3 to day 14 postoperatively. The interesting thing about this study is that there was no actual active exercise that was performed. They simply use the cuffs and the blood flow restriction as the intervention itself, right? So the BFR group, they used a 90 millimeter width cuff. The pressure was 180 millimeters of mercury starting each day, increased by 10 millimeters of mercury as tolerated by the individual. The max average occlusion pressure was 238, that ranged from 210 to 260, and then the control group actually did put cuffs on, however they did not actually inflate them with any additional pressure. The exercise type, none. The frequency, this was done 2 times per day. There was 5 sets of 5-minute occlusion. Sets and reps were done for 3 minutes. And then there in the right-hand portion of the screen, we can kind of take a look at some of the results, which are, in my opinion, pretty impressive. So again, there was no active exercise that was done with the occlusion, but we can see that first in the experimental group, we're looking at the cross-sectional area total, which is the black bars. The gray bars are the extensors, and then the striped bars are the flexors. So the experimental group had a significantly less decrease in their cross-sectional area relative to the control group. Again, within the first 2 weeks post-operatively, there have been studies that have quoted that the cross-sectional area of the quadriceps and the upper thigh can decrease by 20 to 30%. And that's really what we saw within the control group. If you put in that red line, you can actually see that there was a 50% reduction in the cross-sectional area that was lost for the extensors from one group to the other, which again, given the fact that there was no actual exercise and the only intervention was the occlusion itself, this is quite impressive. Okay, and as impressive as the last study and the findings were, it's important to look at this from all aspects. So here's a study that was done in an attempt to replicate the results of the previous. Again, very similar methods, relatively small cohort, same age, almost an even distribution of male to female, same time frame post-operatively. The exception here is highlighted in red with the amount of pressure that was used within the cuffs. So as you recall, in the last study, there was 180 millimeters of mercury that was the starting occlusion pressure, and this was increased by 10 millimeters per day as tolerated by the individual. In this study, however, 130 millimeters of mercury was the starting, and they actually capped it at 180, whereas the last study, the average max was close to 240 millimeters of mercury, so a significant difference there. Additionally, the exercise type also differed here. As you recall, the last study did not do any exercise. With this study, the individuals did quad sets of 20 repetitions within a 5-minute time frame of the occlusion actually occurring. And the results here are shown in the graph, and you can kind of see that just by looking broadly at this, is that there's no statistical significance in the distribution of the quadriceps cross-sectional area change. It really is even more all over the board for the occluded group relative to the control. Now, this being said, the authors of this study also noted a couple of limitations that potentially explain the results and why they differed from previous studies. So one of the things that was critical is that the circumference of one's thigh actually has a important impact on the amount of pressure that was used. And they did not individualize the amount of pressure that was used from one individual to the next. Rather, they had a blanket standard of 130 millimeters of mercury, went off the individual's comfort level, and then capped it at 180 millimeters of mercury, which again is significantly below that of the previous study that had shown the positive results of muscle preservation. Additionally, they talked about their methods in which they actually use the MRI to look at the muscle or quantify the muscle atrophy. They did not use a muscle volume metric that was previously shown to be a little bit more accurate. Rather, they used cross-sectional areas at 40% and 50% of the limb. The other limitation that they said that potentially would explain their results is the reduced amount of load or exercise stimulus that was induced within this study. In my opinion, I think that the last limitation is actually pretty, I don't know, I feel as though it doesn't actually explain the results difference between this and the previous study, because the last study didn't even use exercise, and so they had zero intensity, and yet they still saw the muscle preservation. Rather, I think that the biggest takeaway is the fact that there's a threshold of the amount of pressure that is necessary for muscle preservation in the individuals who are undergoing post-operative ACL rehab. Okay, and here's a third study, also staying with the post-operative ACL patient demographic. It was a little bit larger study done with 44 patients, even split between males and females, and then also a young patient demographic within 29 years of age as the mean. The duration was 16 weeks. It was 180 millimeters of mercury that was used in the lower extremities across the board. The post-operative ACL protocol was used for both the BFR and the non-BFR groups. The frequency of exercise was done 6 times per week. Again, some of these days were done independently, and the intensity was not specifically specified for each of the exercises. But the method stated, and they used the verbiage of relatively low intensity. As we turn our attention to the table there on the right-hand side, we can see first that the individuals started off with relatively equal strength, both in their flexors and their extensors, at least when you're comparing one group, the non-occlusion group, which is represented by the N group, and then the BFR group, which is represented by the R group. Here is that there's not much difference from side to side. If you're looking at the knee extensors, there is a little bit of a strength deficit with the N group holding the edge in each of those metrics. And then similarly with the flexors, is both cohorts are within a similar strength range, if you will. Then so that was again before surgery. If we turn our attention to the next two columns, we can see that 16 weeks after surgery, that the restrictive group again really kind of won out within this study with a p-value showing a statistical significance difference between groups for each of the metrics for not only the knee flexors but also for the knee extensors. Okay, so we've seen in the last 3 or 4 studies or so, when the occlusion pressure or threshold is sufficient, that this blood flow restriction training can have a great effect within the post-operative patient demographic. It can not only improve their hypertrophy and their strength, but also their subjective outcomes are better. And then if you're looking at actual muscle preservation and lack of atrophy, that the blood flow occlusion training can be very beneficial. Now this study here is also related to the post-operative patient demographic. However, it was not performed on post-operative patients, so I think that that's important to note. But commonly, coming out of surgery, really regardless of whether it's arthroscopy or actual reconstruction of the ACL, that NMES and re-education of the quadriceps is commonly indicated and commonly used within clinical practice. So here's a study that actually looked at they broke it up into 4 different cohorts. So they had a control, which is a group that did not do any exercise. I'm sorry, they did the exercise, but without any other modality. The second group just did NMES. The third group did BFR and NMES, known as a combo group. And then the fourth was just BFR. The number of individuals here were 20. So it's 20, 10, and 10 split evenly between the genders, and again a relatively young patient demographic of 29 years of age. The duration done for 6 weeks, 4 times per week. The cuff was done was occluded at 200 millimeters of mercury. The width was 10.2 centimeters, and there's 3 times 4-minute inflation rates for each of the time points. And so you can see here in the diagram to the right kind of the methods or the visual scheme for the NMES group, the BFR group, as well as the combo group. So the exercises range between 0 and 32 minutes, and throughout that time frame, every 4 minutes, they either inflated or deflated the cuff. So the results for strength and hypertrophy are shown here. You can see that all 3 groups that were part of the intervention, the BFR, the NMES, or the combo, all increased in their strength, with the combo group winning out. And then same with hypertrophy, though there was no statistical significant difference between these groups. You can see that each of these groups and each of these modalities, be it BFR and or NMES, really show superior improvement compared to that of the control. Okay, now turning our attention away from the postoperative patient demographic to more of the neurological conditions and what blood flow restriction can have as far as the effectiveness there. So this is a case report. Granted, I know that this is a lower quality of study given that. However, given the study design as well as the outcomes, I believe that it will potentially be an impetus for future studies using blood flow restriction in neurological conditions. So again, one individual, the duration was 10 weeks. It was a crossover study. Phase A was done with 6 weeks for blood flow restriction, and then the second phase, or phase B, there was 4 weeks of no BFR. It was done on a treadmill, so it was blood flow restriction while walking at 50 meters per minute with an occlusion of 120 to 160 millimeters of mercury on both legs. It was done 3 times per week. And then in the right-hand portion of the screen, you can see the heart rate as well as the peak blood pressure and the peak RPE that was recorded during each intervention. Again, these are averages for that said week. You can see that the heart rate there doesn't much change throughout the time. Same with the blood pressure, with the exception that the diastolic does drop over time. With the peak RPE, I think this is important to note that there's an initial increase for the first 3 to 4 weeks, but then the rating of perceived exertion for the individual gradually comes back down to baseline. We'll talk about RPE in relationship to blood flow restriction training in slides to come. Okay, here we have the results. So the timed up and go, which is a test of standing up from a chair, walking 10 feet, turning around a cone, and coming back and sitting down. The time begins when you leave the chair, and then it ends when your bottom touches the chair again. So the quicker that you can do the task, the better the performance. So you have seconds there on the y-axis. On the x-axis are weeks or duration, the individual's performance over that time frame. And what we can see here is that from weeks 0 to 6, that there is a relatively continuous improvement, and then from weeks 6 to 8, the training of the first 6 weeks is preserved without much improvement, and then after that time frame there's a decrease in the individual's performance in the absence of the blood flow restriction training. And so same story here with the sit to stand. The sit to stand, you're timed for 30 seconds. How many times and how many repetitions can you stand up and sit back down from a standard chair of 18 seconds without using your arms. And so there's a gradual improvement, right, from 0 to 6 weeks. There's again a plateau from week 6 to 8, so that training is preserved for the first 2 weeks in both of these assessments. And then after that time frame, there's again a detraining effect that occurs approximately 2 weeks after the removal of the blood flow restriction training. 6-minute walk test. So how far can the individual walk within a 6-minute time frame? You can see the week 0 representing the baseline is just shy of 1,400 feet. That there's a gradual increase in their overall performance for the first 6 weeks. Again, in a precipitous decline after the removal of the blood flow restriction training. The RLS scale, which is known as the restless leg syndrome questionnaire, which is a common symptom that is experienced within this patient demographic, that the lower scores representing less restless legs or symptoms, and then a higher score being more indicative of more disability with this. And so we can see that just like the other tests that have been shown or outcomes that have been shown, is that there's a decrease in detraining effect that occurs from weeks 6 to 10 during the time frame where the blood flow restriction. So interesting results of the effect that blood flow restriction training can have on individuals with neuromuscular disease such as Parkinson's disease, shown in that last study. In this study, they looked at individuals with polymyositis as well as dermatomyositis, which is more of a muscular condition than a true neurological one. And typically the proximal muscles are involved with both of these conditions. So it was a small study, 13 individuals, 12 weeks in duration. The training was 25 to 30 minutes for 2 times a week, and it was specific to leg press and knee extension. You can see that given the frequency and how far along they were in the study, that their sets and reps as well as the intensity changed with a gradual increase in the volume as well as the intensity. And then in the right-hand portion of the screen, you can see that the different subjective variables as well as the change in these variables from the pre to post test after the 12 weeks. And you can see there that really in every category that these individuals subjectively stated they improved. Here are more of the objective measures and outcomes from the study. You can see in that first graph A that the 1RM leg press in kilograms increased across the board, statistically significant as represented by the asterisk sign above. Same with the 1RM leg extension. The timed up and go, as was described in the Parkinson's study, also decreased across the board, statistically significant. And then the TST, which is the time stand test, was also significantly improved in the number of repetitions. So a little bit more of a population that you may not otherwise consider blood flow restriction training or that type of modality, but again, the studies are showing the effectiveness that it has, not only with those with muscular conditions but also with the neurological conditions. And so here's a couple summary points from when we're looking at the effectiveness of blood flow restriction. And this was taken from the second meta-analysis that was originally looked at a couple slides back. So low intensity BFR may increase muscle size and strength effects used when traditional high loading training may be inappropriate or unattainable. 30% 1RM adaptations are greater than that when 20% 1RM are used. The quantifiable muscular adaptations present quickly. Training greater than 6 weeks seem to offer greater returns in strength and hypertrophy adaptations. The BFR training has applicability to a range of populations who may seek to progress strength while reducing loads in the associated tissues, including muscular, tendinous, connective, and bony tissues. And speaking of remodeling, and that is shown here in a recent systematic review that was done by MTOR in 2018. They identified 4 studies that looked at blood flow restriction training and the effects on bone remodeling markers. You can see that the first 2 studies there utilized a relatively small sample size of 18 and 9, a little bit larger in the bottom 2 studies. The first one looked at aerobic training, the second one was strength training, and then the last 2 also looked at strength training at 3 times per week. The conclusions there are listed within the right portion of the screen, and you can by all means read through those and even seek out the sources and the systematic review should you be more interested. Again, the take-home message here is that blood flow restriction training thus far in the early research has suggested that it has a positive effect on bone remodeling, but given the heterogeneity, the small sample sizes, as well as the types of cuffs and occlusion pressures that were used, it's hard to draw a firm conclusions as far as like the actual effect. At least that was the opinions of the authors of this systematic review. So when we're looking at the effectiveness of BFR, it's important not only to look at what has been, but what will be coming. Blood flow restriction research is rapidly expanding. The patient demographics in which BFR research has been and will be applied include, but is not limited to, the following: postoperative clinical trials. If you go on clinicaltrial.gov, you'll see that there are studies currently, at least in the lower extremity, being conducted for knee arthroscopy, ACL, femur fractures, Achilles tendinopathies, meniscus repairs. In the upper extremities, distal radius fractures, rotator cuff repairs, and more general surgeries, including joint arthroplasty and nerve injuries, as well as muscle strains. Those patient demographics that are a little bit more in the margins that have shown benefit are the myositis, astronauts in space where gravity can't provide sufficient resistance, and then geriatric populations is another common research area that is also rapidly expanding, and then even into adolescence as well. All right, so let us take a moment and look at the mechanisms of blood flow restriction and how it's actually having the effects that we've seen. So there's 2 primary factors when it comes to hypertrophy. The first is mechanical tension. The second is metabolic stress. So I tried to lay out a sequence at which each of these factors lead to hypertrophy. So let's start with mechanical tension. So there's an increase in external force and or intensity that leads to increase in active and passive contraction, leading to increased force production, leading to increased mechanical tension. That in itself provides the stimulus for body's cells adaptations. When you're looking at the metabolic stress, it's a little bit different. So this is high volume training that leads to more metabolic stress, such as the phosphate, inorganic ions, the hydrogen ions, the lactate that can build up in muscles during and following exercise. And then with that, it stimulates a more anabolic response from the hormones, and this leads to increases in growth factor as well as muscle and tissue adaptation. So when we're looking at this in the context of blood flow restriction, we can see what stimulus each of these factors have. So mechanical tension leads to hypertrophy via mechanotransduction, increase in localized hormone production, muscle damage as the muscle cells are actually broken down, reactive oxygen species or ROS production, and then increase in fast twitch fiber recruitment. The metabolic stress leads to hypertrophy via increase in systemic hormone production, particularly growth factor, increased fast twitch fiber recruitment, cell swelling, muscle damage, and increased production, again, of the ROS species. So when you're looking at muscle hypertrophy, it's going to be a combination of these two. It's not going to be one and not the other. Depending on the type of exercise, one of them will predominate. So when we're considering these two types of stimuli in the presence of high intensity resistance training and low intensity blood flow restriction, we can see that the metabolic stress is high with the BFR and low with that of the high intensity resistance training due to the lower volume. Again, because with higher intensity, there's relatively lower volume, and with low intensity, such as the 20% to 30% 1RM resistance that is used VFR, there's higher volume training, and then the fact of the occlusion itself increasing the metabolic stress. And then you can see that this leads to secondary mechanisms and relationships relative to the contributions of muscle hypertrophy. So muscle fiber recruitment, there's an increase in muscle fiber recruitment, as we'll discuss later in slides to come, where there's a preferential recruitment of type 2 muscle fibers rather than the type 1. The mechanical transduction and muscle damage is decreased in the BFR relative to the high intensity. And then the systemic and localized hormones in both settings are increased. Cell swelling is only present within the BFR. And then for the reaction oxygen species, the NOS, as well as the heat shock proteins that we'll discuss, these are all relatively increased. There is some question as to whether the reactive oxygen species within the presence of BFR are comparable to that of the high intensity, depending on the source that you read. At least this one in particular says that there's no increase or decrease. This then leads to an autocrine and paracrine action, and we will discuss that in the next slide, which leads to your hypertrophy. So just a reminder, right, of molecular messaging. So autocrine are same cells secreting and receive cytokine signaling on themselves, and then the paracrine is when cytokine signaling is secreted to a nearby or adjacent cell. And then endocrine is the cytokine signal secreted to the circular system, traveling a distance to cells. So again, these are the different types of molecular messaging that is occurring in the presence of high intensity resistance training as well as BFR. There is both autocrine, paracrine, and endocrine messaging that is occurring that leads to their hypertrophy. So let's talk about muscle damage in the presence of BFR. Available evidence does not support the hypothesis that BFR in combination with low intensity exercise increases incidence of muscle damage. Evidence suggests minimal to no muscle damage is occurring with this type of exercise. The supporting factors that lead the authors to this conclusion: no prolonged muscle soreness, decrements in muscle function, no prolonged swelling, muscle soreness rating similar to submaximal low load control, and no elevation in blood biomarkers suggesting muscle damage. when you're looking from the cellular aspect, if there's not actual muscle damage occurring, then what are the processes that are actually taking place? And so, though this is a busy diagram, I think that it actually lays out the cellular functions that lead to hypertrophy within the occluded muscle. And so this was published by Jeremy Lenicky in 2012. And we're going to step through this in the coming slides so that you have a better idea as far as the different mechanisms at play when it leads to hypertrophy in the presence of blood flow restriction. So let's talk about metabolic stress. So you have the cuff, which then leads to an increase in lactate, an increase in ATP, and an increase in hydrogen ions. This leads to a decrease in the pH over time. This is then signaled or identified by the group 3 and 4 muscle afferents, signals to the dorsal root of the spinal cord, sending signals up to the cardiovascular control center in the brain stem to increase the sympathetic activity, increase heart rate, increase arterial blood pressure. At the same time, this signaling leads to hypophyseal portal system, also known to stimulate the hypothalamus, and you have growth hormone, reacting hormone, that then leads to signaling of the pituitary gland, leading to growth hormone increases of up to 290 times, which then stimulate IGF-1 and MGF, which are important markers when it comes to muscle hypertrophy and growth. So the insulin-like growth factor, will break it down as to what it can actually do and the effects that it has. So it's unclear if IGF activity is directly increased in response to the occlusion training or more indirectly, as we just demonstrated with the release of the growth hormone through the pituitary gland. Takano et al. Found that a significant increase, whereas 2 other studies found no increase, possibly due to the low intensity of the exercise. So again, it shows that there is a little bit of some ambivalence there. It is postulated that the IGF may not be necessary for muscle hypertrophy when other factors such as myostatin, heat shock protein 72, which we will discuss, and the nitric oxide synthase are changed in favor of muscle growth. So even though there is relative question as to, or discrepancy I should say, from one study to the next, as well as as to whether insulin-like growth factor is actually increased, and if so, by how much, it may not actually matter in the presence of these other hormones or in factors that are released with the occlusion training. Okay, so sticking with the theme of metabolic stress, and it's important to, if you're going to understand this pathway, that we define a couple of terms. So the nitric oxide synthase enzyme responsible for converting L-arginine into nitric oxide. The nitric oxide is electrically neutral molecule capable of moving with ease through tissues. And then neuronal NOS is found in the transmembrane dystrophin protein complex of skeletal muscle. So the neuronal NOS is a form, or is a type of nitric oxide synthase. So at rest, NOS produces low levels of nitric oxide, which maintains satellite cell quiescence, meaning that they're quiet. During exercise-induced contractions, however, mechanical shear force and or increases intracellular calcium concentrations lead to the NNOS, or the neuronal NOS activation. The inclusion plus exercise increases calcium ions increase and or reperfusion, leading to further activation and augmenting NNOS activation within the cell in the presence of occlusion, thus stimulating the satellite proliferation, leading to the hypertrophy, as those satellite cells then can become not only helpful in repairing, but also new muscle cells. Okay, and here's a little bit closer look at that cellular pathway and how nitric oxide actually increases the satellite cell activation. So again, you have the anabolic stimulus and exercise in the presence of occlusion, which gives you an augmented increase of nitric oxide, which stimulates the hepatocyte growth factor and inhibits the myostatin. This activates the satellite cells, as well as, again, inhibiting the myostatin, which is important for allowing cellular repair and protein synthesis to actually occur. Okay, so if we're now concerned about fiber type recruitment, which is also associated with the amount of stimulation of hypertrophy and protein synthesis that occurs after exercise, we can kind of look at blood flow restriction in combination with exercise and how that stimulates or stimulation may lead to a recruitment of type 2 fibers in larger motor units. So in the presence of blood flow occlusion, there's a relative decrease in oxygen available, and then this leads to a decrease in force production, which then there's a progressive recruitment of additional motor units in order to compensate for that decrease in force production. With more units, motor units being recruited, it's likely that the higher level threshold motor units, the type 2s, will then be recruited. So an increase in motor unit firing rates and motor unit spike amplitude is associated with arterial occlusion, suggesting that the recruitment of high threshold motor units, i.e. fast twitch fibers, is affected by not only force and speed of the contraction, but also the available oxygen. And so it's been well documented, as shown by the diagram to the right, is that the higher force that is utilized within an exercise and the higher speed that is utilized at the higher threshold motor units, or the type 2 fibers, will be recruited. The new additive to this is that the available oxygen may also play a role in preferentially recruiting the type 2 motor units and fibers, which have a higher affinity and ability to hypertrophy. So here's a study that highlights exactly that. So subjects were male, 25 to 40 years of age. They performed bicep curls at 40% and 80% 1RM at occlusion levels of 0, 50, and 100 millimeters of mercury. Pneumonic occlusion with a cuff of that was 90 millimeters wide and 700 millimeters long. So here we talk about EMG, or integrated electromyography, which is really essentially the amount of neural input that is going to the muscle, and this demonstrates that there's no difference in EIMG activity between the low intensity occlusion versus the high intensity occlusion. Training suggesting that a greater number of fast twitch fibers are activated at lower intensities, right? And so this is visualized on the graph to the right. So on the y-axis you have the relative EMG, or muscle, the neural muscle activity. On the x-axis you have 0, 50, and 100, representing the different occlusion pressures. So at 0 occlusion, you can see that there's a large discrepancy between the high and low intensity relative, right? So, but as the occlusion increases, you notice that the discrepancy between the EMG activity for the 40% and the 80% 1RM lifts becomes smaller and smaller, again suggesting that in the presence of occlusion, that there's going to be a lower threshold for the higher threshold motor units. Essentially, again, more motor units being recruited, as represented by the higher EMG at a lower intensity exercise. So continuing on, the multi-variable approach, which blood flow restriction training causes muscle hypertrophy, we're going to focus on the mammalian targeted rapamycin pathway, also known as MTOR. You can see that it kind of is visualized there with the red circle to the right. So increased rates of protein synthesis lead to skeletal muscle hypertrophy in response. The mTOR pathway regulates numerous components involved in protein synthesis, initiation and elongation factors, and the biogenesis of ribosomes themselves, which are critical because this allows for the synthesis of new proteins. The S6K1 phosphorylation, a critical regulator of exercise-induced muscle protein synthesis and a product of the mTOR pathway, is a critical component when it comes to the effects of the mTOR pathway has on protein synthesis. And it's been demonstrated that this S6K1 phosphorylation is increased by 3 times immediately post-exercise with occlusion training, and it can remain elevated up to 3 hours post-exercise. Thus, again, in layman's terms, a product of the mTOR pathway is this S6K1 phosphorylation, which has a more direct link to the amount of protein synthesis, and that this phosphorylation protein is increased by 3 times when exercise is performed in the presence of occlusion. Okay, sticking with the mTOR pathway. So one of the inhibitors of the mTOR pathway is the RDD1, or regulated in development and DNA damage response. Right? So this, which is normally expressed in the states of hypoxia. It is, however, not expressed for whatever reason in the presence of occlusion training, even though there is essentially a hypoxic event occurring. RDD1 leads to a decrease in protein synthesis through the inhibition of the mTOR pathway, and with no increase in RDD1, there is an increase or lack of inhibition of the mTOR pathway, leading, as we stated in the last slide, to the increase in S6K1 phosphorylation and thus protein synthesis. All right, so continuing with the cellular mechanisms at which blood flow restriction training helps with protein synthesis is the inhibition of myostatin. Now, myostatin is a myokine, a protein produced and released by myocytes that acts on muscle cells' autocrine function, right? So autocrine meaning that the cells are acting on themselves to inhibit myogenesis, or the growth of myocytes, or muscle cells. So the mutation of this gene results in overgrowth of musculature in mice, cattle, and humans. It inhibits satellite proliferation, and myostatin is expressed in adult satellite cells. Or when it is expressed, it leads to satellite cell regulation of quiescence, meaning that they are quiet, and self-renewal, showing that it does play a role in adult myogenesis. So myostatin, in regards to protein synthesis, is not good because of those factors that it has on the satellite cell proliferation. So in the presence of mechanical overload, high intensity training, or low intensity BFR, there's a decrease in muscle myostatin gene expression. This is good because this then allows, in the presence of BFR, a favorable hypertrophic changes in myostatin as a result of hypoxia and or increase metabolic subproducts. Because myostatin is inhibited, as we also saw its inhibition with the nitric oxide, this allows the satellite cells to come out of that quiescent state and then be more apt for protein synthesis and muscle repair. Okay, so the next factor that we will talk about is the heat shock proteins, which are induced by stressors such as heat, ischemia, hypoxia, free radicals, all of which are produced within BFR training. And so the HSP, as we'll call them, their purpose are chaperones to prevent the misfolding of aggregate proteins. useful to slowing down atrophy. For example, HSP72 plays a protective role in preventing protein degradation during periods of reduced contractile activity by inhibiting key atrophy signaling pathways. The primary pathway involved in mediating protein degradation is the ubiquitin proteasome pathway, and so the HSP helps to prevent that pathway from occurring and causing protein degradation. So in vivo studies have shown that an increased level of HSP70 is sufficient in preventing skeletal muscle disuse atrophy. HSP70 inhibits the promoter activation of androgen 1/muscle atrophy F-box, also known as MAFBX, a muscle-specific ring protein, MURF1, transcription factors which regulate their expression, the FOXO and nuclear factor of P plus NFP. Again, another molecule within the pathway. Occlusion training leads to an increase in HSP72 in a rat model, postulates to be a potential mechanism. So again, I understand and appreciate that this is relatively tedious, so hopefully this kind of more layman's diagram here will kind of help. So BFR leads to an increase in HSP72 and 70, and this then inhibits the ubiquitin pathway, allowing for muscle hypertrophy to then occur. All right, so that is essentially the take-home of how the HSPs help to allow hypertrophy and muscle regeneration after BFR. Now, we did mention at least one of those ACL studies that showed that there is an increase in muscle, or I guess we should say a preservation of muscle in the absence of exercise. And so here are a couple studies that have also shown that. So the first one is the ACL study that we discussed previously. Kubota in 2008 also showed a similar effect with the cast immobilized limbs that leads to attenuation and decreased muscle size measured by leg circumference and muscle strength. Also by the similar research group, lower measure of 50 millimeters of mercury led to a decrease in muscle weakness by chronic unloading, but no effect in attenuated changes in leg size. That's also consistent with the 2016 study that we saw that tried to replicate the Takarada 2000A study, though it didn't have 50 millimeters of mercury. That study used 130 to 180 millimeters of mercury, but this kind of shows the fact that there is a certain cutoff or threshold in which the occlusion needs to be in order to preserve the muscle size. So what is the mechanism that is going on here if there's no metabolic stress as suggested in the cellular mechanisms previously discussed? So acute increase in real-time ultrasound measures muscle thickness. Changes were maintained following the removal of the cuff, leading to acute changes in muscle thickness, or actual acute increases in muscle size, i.e. muscle swelling, and not attributed to venous pooling. So if you flip back several slides to the diagram of the primary and secondary mechanisms of muscle hypertrophy as laid out between BFR and high intensity, you'll note that there's actually a muscle swelling that was discussed. And so this muscle swelling effect is said to be what allows BFR to be effective in the presence or the absence of exercise. So Fried 2010 observed a greater acute increase in muscle size measured by the circumference with BFR resistance training versus resistance training alone, again suggesting that at least in the article, they discussed that is more of this muscle swelling effect that is responsible for the increase in circumference. Abe 2006 and Ozaki in 2011 both discussed the swelling may also help to explain the increase in muscle size and strength previously observed by the slow walking mode of exercise with BFR. So again, it's in the absence of exercise, but in the presence of BFR, that the leading hypothesis of why this leads to attenuation of muscle loss is due to the muscle swelling, and this muscle swelling is not or should not be mistaken as simply like the venous pooling that can occur in the fact that blood flow occlusions at certain thresholds will clamp the venous system. Okay, so this slide simply summarizes what I was discussing with the swelling hypothesis in the absence of exercise. So BFR leads to increased H2O within the cell, causing it to swell. This in itself causes a stimulation of the MTOR pathway, which we have already discussed, and thus being the potential leading cause as to why the occlusion training in absence of exercise leads to muscle preservation. However, there are limitations, and so the swelling hypothesis has only been really demonstrated in hepatocytes, and it's unknown how well this mechanism may translate over to human skeletal muscle tissue. Future cellular research is obviously needed in this regard, not only because this swelling mechanism may really need to be proven out within the human skeletal muscle, but then it also may have important clinical implications for populations contraindicated for exercise. So I can certainly understand that the mechanisms by which hypertrophy occurs in the presence of BFR can be tedious and somewhat difficult to understand. I do encourage you that if you want to learn it more in detail, that you pull some of the references, in particular the Lonicki 2012 article, which really has that initial cellular diagram that can be really helpful in better understanding and adding detail to the information that is already presented here. Moving on, we'll look at the safety and side effects of blood flow restriction. Okay, so when we start to consider the safety and side effects of BFR, it's important, I think, worthwhile to understand what is most commonly being done with this type of training. So this was a survey that was given out in Japan in 2016, occurred over about a 2-month time frame. There was 232 facilities in Japan that responded, counting for over 12,000 subjects. The males and female distribution is shown there, 30 and 70%. So looking at the graph here, you can see first off the distribution in age groups at which BFR is actually being applied. Everywhere from adolescents less than 19 years of age to individuals over 80, with the majority of individuals between 30 and 60 years of age. Here we look at the side effects that patients reported with and during blood flow restriction training. So the things that really stand out are subcutaneous hemorrhaging, which essentially is bruising around the areas where the cuffs were applied. This particularly happens more often in the upper extremities, but can also occur in the lower extremities as well. And then symptoms of anemia have also been of high prevalence, meaning lightheadedness, fatigue, mild dizziness, or other side effects. But again, you can see the list here, but those are the two biggest ones that So in addition to the prevalence and side effects that were listed on the previous slide, it's important to also look at the rare adverse events that can occur. So this was another survey that was sent out in 2006, also in Japan, that included 106 facilities. The authors also included 3,500 subjects that were treated in their clinic from 2007 to 2011. In the first column, you can see the adverse events listed, and then the N, meaning the prevalence, and then the common comments there. So we'll step through these one at a time. So the brain hemorrhage occurred in one individual. Obviously, this is quite serious. The authors compared this to sudden death that it can occur in the athletic population. Individuals less than 35 years old, hypertrophic cardiomyopathy, cardiomegaly, coronary artery disease, malformation, aortic rupture, and brain hemorrhaging are all risk factors for sudden death within an athletic population that can occur. And so they kind of describe this incident as one in which there was sudden and unexpected. And individuals who are 35 years of age or older, 80% of the sudden deaths that occur are either brain hemorrhaging and or coronary artery disease. So in their opinion, this one unfortunately could not have been prevented, at least what I read between the lines in the article. So the venous thrombosis occurred in one individual as well. BFR-induced fibrolytic state when the occlusion is occurring. So I didn't quite understand the cellular mechanisms behind this, given the fact that the blood is actually pooling within the venous system, particularly in the lower extremities. But it is, I guess it has to do more with the cellular response and the physiological response that is induced by the restriction. So they also compared this to healthy populations as well as pregnancy and postpartum individuals that have a higher prevalence rates of venous thrombosis compared to the BFR population. Transient numbness, the prevalence was not reported, but the subjective reports were that it lasted a couple of days. I also could not find any papers that specifically spoke about this topic. Rhabdomyolysis occurred in one individual, and this should be quite surprising given the information that we know on the mechanisms of BFR. And so the risk factors here are poor hydration, heat and humidity environment, and the authors also spoke on the fact that rhabdomyolysis is rare in BFR due to the low intensity and minimal muscle damage that has been shown to occur. Venous injury and induration can occur. Its prevalence rate was not reported. The females were most of highest risk for this, so 30 to 50 years old, spontaneous resolution within 1 to 2 months post-injury, repeated pressurization and depressurization prior to the initiation of BFR and or KATSU training was recommended as a means of allowing the venous and the vascular system to accommodate to the additional pressure. And further considerations and conservative management should be taken in the presence of sedentary individuals. Obviously, their bodies may not be used to not only the exercise, but in particular the added occlusion and stress that is put on the vascular system with KATSU and or BFR training. And then finally, you should adhere to the KATSU training timeframes of 15 to 20 minutes. We'll discuss this more in the practical and clinical application section. All right, so let's get into potentially screening individuals if you were to actually apply blood flow restriction training within the clinic. So given the fact that you're going to have people exercising and they're going to be under high metabolic demand, it may be recommended that you consider including a PAR-Q or a PAR-Q plus with everyone that you have exercising. This should be essentially a standard of care, mostly seen in the private practice and or personal training settings. As the larger medical centers, you have enough information to potentially fill this out for the individual and to understand whether the individual is at risk or at least stratifying their risk when it comes to exercise. Additionally, this is like a screening and intake that is recommended for KATSU training. So the intake information is there in the first column. So symptoms, history of disorder, lifestyle disorders, family history, lifestyle habits, resting EKG, if and when available. And then you can see the criteria. So if there's criteria that is checked off, then you can look in the third column as to what is indicated. So if indicated, then actions to be taken are an exercise tolerance test if any of the 6 symptoms there are listed. When it comes to history of disease, if it's a cardiovascular disease, exercise tolerance test is indicated. Orthopedic and/or joint disorder, obviously an orthopedic examination would be recommended. Same thing with the lifestyle disorder, so assess severity of selected criteria, which we will present in the coming slide. Family history, same as ACSM, looking for cardiovascular risk within the family. If they meet that criteria, it's again, I believe it's below 45 for male and 55 for female of immediate descendant, then exercise tolerance test is indicated. Lifestyle habits, so sedentary lifestyle, smoking or alcohol, lifestyle guidance is recommended. And then resting EKG, though this is relatively hard to get, particularly within the physical therapy setting. Exercise tolerance test would be indicated if there's any myocardial infarction or history of that seen on the EKG, ST segment abnormality, ventricular arrhythmia, or important observation. Okay, then here are the indications, precautions, and contraindications of the different diseases that were discussed on the previous slide. So high blood pressure, diabetes, hyperlipidemia, and obesity. The indications are listed there in the second column. You can read through them. It's pretty self-explanatory. So 140 over 159 systolic, 90 to 94 diastolic pressures, fasting blood glucose, 110 to 140. So again, this slide is essentially really just a reference slide for you, so you can better identify those individuals who are of more concern when it comes to the blood flow restriction training and or KATSU training. So the total cholesterol, total glycerides are abbreviated by TC and TG. The asterisk signs show males greater than 40 years old and females greater than 50 that require exercise tolerance test. Okay, now we have a good understanding of the intake information that should be performed at the initial blood flow restriction training or the initiation of this. I wanted to look at the surveys that were sent out in 2016 to those 232 facilities, including over 12,000 subjects. And what we can see here is the adherence or the prevalence of each of these measurements by each of the facilities. And what is somewhat surprising to me is the lack of adherence, right? So that almost all, obviously, nearly all of the facilities conducted an interview. Almost 80% to 90% included blood pressure and heart rate or pulse rate. However, after that, body weight, body composition, girth of limb, which is going to be critical to applying the proper occlusion, which we'll find out more about later, and then the blood sampling, the EMG or ECG, the oxygen saturation, 1 RM. Very few are conducting these types of objective measures now. So my question is, if you don't know someone's 1 RM, how are you going to ensure that they're using 20 to 30% of that? I imagine that it'd be quite difficult, and even a physical fitness test, that the very least something such as a 6-minute walk or something to give you an idea of their aerobic and or physical fitness level, I think would be certainly indicated. And so this was the result of the initial training. Looked at the checklist for subsequent training sessions, which include, again, an interview, blood pressure, heart rate, body weight, body composition, similar results, if you will. I was also pretty surprised by the RPE levels, so only almost 25%, I'd say, of the clinics actually captured this information. And then not only that, but when you look at which they're capturing this information. It's all of the board, right? So it's everything from once a week to 6 months, right? And so the highest prevalence is once a month. These facilities are actually taking into account this information. So I think that this information in general really just speaks to the fact that as clinicians we need to be a little bit more diligent when performing safety checks in the presence of blood flow restriction training and or KATSU training. Okay, and so one other thing that that may be of use to you is a blood flow restriction risk stratification tool. So this was modified from the version that was presented in Nakajima in 2011. So I thought that it would be a little bit easier when performed in put into a check mark format. So it's essentially a point system. You can see that the points run along the top column there where it says 1, 2, 3 through 5. And then you have the criteria. And so each check box gets depending on the column, gets a certain number of points assigned to it. And then you have a column score down there at the bottom. And then you have an aggregate score adding everything up together. So the interpretation of the results would be anything equal or less than 1 point would be individuals who represent a low risk, 2 would be a mild risk, 3 would be a moderate risk, and then 4 would be high risk individuals and really are essentially contraindicated. So and those right off the bat would be pregnancy, history of DVT, history of PE, antiphospholipid, antibody syndrome. I wasn't familiar with it, but should your patient have it, don't do blood flow restriction. So utilize this tool as well as this slide as a reference. Again, it was not in its original form, but formatted from Nakajima. Additionally, for those who like a decision-making tree and algorithmic approach, here's one that was presented by Scott et al. In 2014. So again, we'll kind of just step through this. So does the individual have any contraindications to BFR? If yes, then consult a physician before implementing BFR, obviously. If BFR is then approved, you would go to the right side of the decision tree. Is the individual mobile? No. Then apply moderate BFR alone to the limbs. If yes, could the individual tolerate loads of 20 to 40% 1RM? If yes, then could the individual tolerate high loads of resistance training? If yes, combine traditional high load resistance training with low load BFR training. If they cannot tolerate the 20 to 40% 1RM, then you would combine low load cycling / walking exercises with BFR. If they can, then you can go combine low load resistance training with BFR. Again, if they can tolerate the high load, then by all means you want to do the high load and low intensity BFR together. So yeah, I thought it was really helpful to kind of think through the process. This in combination with the risk stratification tool presented in the last slide, as well as the initial screening criteria. So almost unanimously across the literature when it comes to blood flow restriction training and or KATSU training, it's said to be quite safe as long as the proper precautions are taken into account. And we will see studies upcoming that look at the hemodynamics in the presence of blood flow restriction training. But one study in particular, Sprenger in 2015, called into question the lack of recognition of the exercise pressor reflex that occurs within blood flow restriction training. And so if you're not familiar with the exercise pressor reflex, it's 3 components to it. So in the presence of exercise, there's 3 effects that occur. So there's a central command center that will then stimulate the brainstem and cardiovascular control center as exertion picks up. And then there's local information there that will also be sent up afferents from the working muscle that is actual increase from the EPR, or the exercise pressor reflex. So that is local to the muscle mechanoreceptors and metabolic reflexes send afferent signals again to the brainstem to control the cardiovascular system. And then third is the carotid baroreceptors, as well as the carotid reflex afferents that will also send signals to the cardiovascular control center in the brainstem, leading to parasympathetic and or sympathetic response. So in the presence of exercise, there will be an increase in the sympathetic nerve activity, leading to like increased systemic resistance vessels, increased arterial resistance, and increased or decreased venous capacity. And then also the heart will undergo an increase in heart rate, cardiac output, increased contractility, arterial blood pressure, etc. Now, so this is like under a normal circumstance of exercise. Now, So here, now in the presence of blood flow restriction training, the exercise pressor reflex, as well as the input from the central command center, is increased and augmented by the increase in metabolic demand that is occurring at the muscular level and the signals that are being sent from the afferents. And so this then would lead to an abnormal increase in the sympathetic nervous system drive, as well as in the exercise pressor reflex, which is said to further augment the hemodynamics of the heart rate, cardiac output, contractility, etc., significantly more so than the normal exercise scenario. Now, this is more of a kind of a scoping review and opinion commentary paper, but their purpose in writing it is to, one, draw light to it, because it has otherwise been fairly quiet within the blood flow restriction and KATSU training models. So individuals with cardiovascular disease, hypertension, heart failure, are especially at risk for deleterious cardiovascular events when performing BFR. Healthy individuals, resistance training, systolic and diastolic greater than 300 millimeters mercury in the absence of BFR. Like this just generally occurs, right? So young, healthy bodybuilders have shown that on leg presses they can get systolic and diastolic pressures of 320 and 240 respectively. And then even in the exceptional cases, well over that, where both systolic and diastolic values are well over the 300 millimeters of mercury. Increased venous compression leads to increased venous pressure, leads to potential valve damage and chronic venous insufficiency, is their argument. Additionally, the spikes in arterial pressure plus BFR leads to an even higher increase in risk of cardiovascular events. And then they also even mentioned the fact that the pain response with BFR may be increased due to the central command and EPR function, leading to the sympathetic nervous system afferents and increased mean arterial pressure in healthy individuals to what otherwise could potentially be considered dangerous levels, but increased risk levels. And so, again, these are the conclusions that they were drawing and the arguments that they were making within the paper. Again, I think it's important that we recognize the pressor reflex, but at the same time, as we will see in the clinical applications, that the difference in hemodynamics between the high intensity exercise and the low intensity BFR is not that different, with the exception sometimes of mean arterial pressure depending on the form of exercise. And so I think it should be important to note that arterial waveforms show that vascular changes appear to be localized within the musculature rather than systemic as proposed by Spranger, and no negative effects on large vessel stiffness, augmentation index, and or aortic blood pressure have been shown. Correlations between the BFR-induced spikes in arterial pressure and risk of cardiovascular events is unknown. So again, it's more of a theoretical model that they are presenting. Further research is needed before BFR can be fully endorsed according. And so here's kind of a comparison between BFR and high intensity resistance training. So stroke volume, it's going to decrease with BFR. There's no change with high intensity resistance training. Blood pressure will increase in both. Heart rate will increase in both. The fibrinolytic potential will increase with both, which is again somewhat in controversy with BFR according to the Nagasaki article that we saw, right? And then the coagulation activity seems to be unaffected in both. Oxidative stress increases more in the high intensity. Post-occlusion blood flow, comparable. Muscle damage, again, less in BFR. So when you compare the hemodynamics and some of the more pertinent parameters between the BFR and the high intensity resistance training, we can see that by and large, if anything, the high intensity resistance training shows more spikes and increases than does the BFR. And so, in conclusion, with the article that presented that information, the current research on blood flow restriction training with respect to safety outcomes confirms earlier reports that BFR exercise, when used in controlled environments by trained, experienced personnel, provides a safe and training alternative for most individuals, regardless of age and training. As further evidence to back up the statements by Lenicky in that last slide, here's a study. It's one of its kind in the sense that it actually used hypertensive women as its cohort and as its inclusion criteria. So the study design is a randomized crossover study. The subjects, there was 18 of them. They were greater than 60 years old. There was 3 sessions of exercise that were performed. Each session was randomized. So again, one individual could cross over, hence the crossover design, from one of these different cohorts to the next within the study. So the control scenario was no exercise. The second scenario was 20% 1RM with BFR, and the third was strength exercises at 65%, or what could otherwise consider it moderate to high intensity 1RM strengthening. The cuff was applied, was 90 millimeters. The type of exercise was knee extension. The volume and intensity was 3 times 10, 1 minute rest. BFR was 20% 1RM, etc. The tempo at which they were lifting was 2 seconds up, 2 seconds down, 40 seconds per set, and 4 minutes rest in between. And so the result, actually look at the hemodynamics. This is the systolic blood pressure. The red line denotes the blood flow restriction, the blue line the scenario of the 65% 1RM, and then the yellow or gold line representing the control. And what you can see is that there's no statistical significance or even really any difference between the response from the BFR versus the 65% 1RM group. When you look at diastolic, it's relatively similar. The only difference here that you could know is that the difference in the resting between the second and third set with the BFR group is slightly above that of the 65% 1RM. But again, it's relatively comparable to the controls individuals who weren't exercising at all. And finally, when you're looking at cardiac output, well, which takes into account, again, the heart rate as well as stroke volume, and we know that the stroke volume slightly can decrease with the BFR, given the fact that you're pooling some of the blood in a limb, be it upper or lower, in this case the lower. And so we're not surprised to see that the decrease in the cardiac output between the blood flow restriction and that of the 65% 1RM. But again, the difference between that and the control is relatively low, suggesting that, again, that the hemodynamic response, even in hypertensive women with resistance training and BFR, shows to be relatively safe in the hemodynamic responses. Here are a couple of basic and I guess summarizing points when applying BFR in a safe manner. So first, confirm no contraindications. Obviously for normal exercise, see Part Q on slide 61. The hemodynamically unstable individual patients, you can screen these out with the intake information on slide 62 and 63. Should not partake in CAT-2 training except clearance has been provided, like by either a cardiologist or what they otherwise consider an expert. So the thrombotic disease patients are contraindicated. It's important to notify the patient of the hemorrhaging that can occur underneath the cuffs prior to the initiation of the training, especially more likely in the upper extremities. Individual trainings for subjects, physical capacity and conditions, you should perhaps have them do a strength test and or aerobic test prior to the initiation. It's important to obviously build relationships and trust with regardless of whether you're doing BFR or not. Pay attention to prodromal symptoms for syncope, fainting, dizziness, lightheadedness, etc. Older individuals greater than 65, bedridden, post-operative patients, obviously DVT risk. Always have an AED available. Short-term and low-term intensity loads. So high intensity loads has little effect, but it has a much rather dangerous increase in the hemodynamics. The long duration, so upper extremities greater than 15 minutes, lower extremities greater than 30 minutes should be somewhat avoided. Contraindications, if a patient is ill or not feeling well, obviously BFR may not be the best bet given the additional stress that is put on the sympathetic system. If unsure about the medical condition, seek specialist contact. Consult. So again, those are basic 12 principles that you can live by when performing BFR, as well as the risk stratification tool and the other information presented within this. Great. Now, so we get to the practical and clinical application aspects in the fifth. So we're going to start off with the survey so we get a good idea of what the actual current practices are as of 2016 when it comes to CAT-2 and blood flow restriction training. So again, just a reminder of the age demographics that this was applied to, anywhere from less than 19 to over 80 years of age, males and females, about a 30 to 70 split, 12,032 facilities. So it can be said that occlusion pressure, intensity of training, number of sets, and duration of training unit remain unclear. That's according to one source. Again, the training has only really been outside of Japan and particularly within the United States since 2008, so about the last 10 years. And we're certainly aware that that research can certainly lag behind clinical practice, and this is indeed the case here. So when we're looking at the different types of exercise modes that BFR has been applied to within Japan, we can see that it's essentially all over the board, everything from sports performance and gymnastics, yoga, Pilates, all the way up to just body weight training, which shows to be the highest prevalence. When we're looking at frequency of exercise, again, relatively all over the board, right? There are some high spikes there with either 1 to 2 times a week and then 1 to 3 times a month, which is less than ideal when you're looking for the actual effects of hypertrophy and strength that we've discussed previously. And so as we get into it here, we will kind of specific recommendations that are evidence-based at this time point to the best of our ability. So when you're looking at duration, 20 to 30 minutes, even 30 to 40 minutes, and coming in third is longer durations of 40 to 50 minutes. Again, when we're looking back at the safety precautions, it is apparent that practice is not always following those recommendations with these longer durations here. So, though it can be understandable that there's lack of consistency between parameters of exercise, particularly within blood flow restriction and KAATSU training within clinical practice. It's a little bit more surprising to see such a discrepancy when it comes to actual research. And so this slide kind of demonstrates that, though there's consistency within the exercise intensity to some extent, when it comes to the actual protocol, there's a wide variety as to what was used, whether it be 3 sets of 15 reps with 30 seconds rest, or the more classic 30, 15, 15, 15 repetitions with, again, 30 seconds rest, or even looking at the walking. So you have walking for 20 minutes, or you have walking for 40 or 52 minutes, or you have cycling for 15. So it's clear from this why there is discrepancy as far as like the optimal dosage of BFR. As of 2014, Scott et al. Did a nice job, I felt, of kind of summarizing what is best evidence practice when it comes to the parameters here. So cuff application, proximal to the limb to be trained. Trunk muscles also benefit from BFR during multi-joint exercises, so consideration of those is noteworthy. Wide cuffs, so the cuffs width does have a implication on the amount of occlusion that is actually occurring. So the wider cuffs, given by the measurements there for the legs versus the arms, inflatable cuffs and elastic knee wraps may be most practical just due to their ease of access. Inflatable cuffs, 50 to 80% of pressure to occlude arterial flow at rest, meaning that you have to actually take the arterial pressures prior to doing so, which can be somewhat challenging when it comes to the femoral artery. Sometimes it has been applied where individuals have taken a brachial pulse and then applied that pulse to that of the lower extremities, which it can't act. That's a less than ideal and suboptimal means of getting to that 50 to 80% of pressure. Elastic wrap should feel snug but not substantially restricted. Completion of desired repetition scheme, meaning that they should be able to complete the repetitions and sets that are asked of them. All right, and then occlusion pressures are BFR alone is attenuated due to decrease in muscle mass and strength. BFR plus walking / cycling, moderate increase in maintenance of muscle mass and strength. Low load resistance training exercises plus BFR, as we know, substantial increase in muscle mass and strength. Type of exercise that can be tolerated should be considered before deciding on an appropriate BFR strategy. And then getting to the type of exercise. So both single and multi-joint exercises can be beneficial. Hypertrophy between limbs and trunk muscles following multi-joint BFR training may be disproportionate. So that's important to note, given the fact that the trunk muscles, though, are benefit from the multi-joint exercises. They don't actually get the benefit of the BFR that only occurs distal to the cuff. Exercise load, 20 to 40%, 1 RM MVC. Multiple sets of low load BFR exercises provide similar metabolic stimulus to high load training, but may not replicate neural demands, which is interesting because we've previously kind of discussed that though the neural demands and neural adaptation may be somewhat lagged when from a time standpoint with the BFR, that over time that the neural adaptation can actually be higher than that of the higher intensity. So volume 50 to 80 repetitions is usually recommended. Again, you can see the standard scheme, 30, 15, 15, 15 equates to 75 repetitions total. And again, when your idea is that you want to increase a metabolic demand, it's important that you have higher volumes in the presence of low intensity. Rest intervals, 30 to 45 seconds are standard. Clinical populations, 2 to 3 training sessions per week is sufficient. In the athletic populations, you can bump that to 4 times a week in addition to normal or high resistance load, particularly potentially within season where you don't want actual muscle damage and you want to reduce the overall joint stresses. From other additional sources outside of that of the Scott et al. Summary review article, rest between 30 and 60 seconds versus 90 seconds can alter the actual post-training endorphins and hormones that are released. So it's important that you should potentially consider that depending on the hormones that you want to elicit. Duration, as previously stated, that the longer duration, 6 to 10 weeks, is potentially more beneficial to augment the effects of strength as well as hypertrophy. All right, so those Scott et al. Did a nice job of kind of presenting the evidence-based practice. Here with the cuff pressures, there's been an ongoing debate as to what is optimal, and so here are some of the methods that have previously been attempted. So standardization restrictive pressures relative to the brachial systolic blood pressure. There's no evidence to suggest that this is a good estimate in the lower limbs. Additionally, it's been shown that the brachial systolic blood pressure not able to explain additional variances in the estimation of lower body arterial occlusion pressures. So lower extremities, they've said, okay, well, maybe we can standardize it to 80% of total arterial restriction, which has good responses in hypertrophy and strength. However, the 50% total arterial restriction leads to maximal EMG and increase in acute decrements in torque during and following knee extension exercises. And that was comparable between 50 and 60% occlusion. So essentially what it's saying is that the fact that 50% has been shown to actually maximize the EMG despite hypertrophy and strength also showing to be increased at 80%. So again, there's a wide variance there as far as the amount of pressure that is actually necessary. One author has tried to standardize it based off subjective report of pressure, 7 out of 10 with quote-unquote no pain, occluded venous return without stopping arterial inflow. However, there's this has previously been countered by other authors, limited difference in ratings of discomfort during exercises across a wide variety of pressures. Perception may not be the best estimate of actual restrictions. This came in combination or within a review article. This data, however, the author noted was not yet published, but it was stated that in their opinion and within their clinic, the perception was not accurate as far as like standardizing the occlusion. Okay, here we can see that one of the other variables, and to date probably one of the best clinically applicable ones, is taking the circumference measurement of the limb in question. So the circumference measurement you can see there in the blue box that's taken a third of the way down the thigh between the inguinal crease and the superior border of the patella. And then you can see that the pressures respective for each of the circumference measurements would equate to approximately 60% of the complete arterial occlusion pressure, which, as we saw on the previous slide, was sufficient for getting maximal EMG activity and deficits within the torque during and thereafter, showing sufficient not only motor unit recruitment with the higher EMG, but also metabolic decrements in the force production. So in addition to the circumference of the limb, you also want to consider the width of the cuff. Those recommendations are provided a couple slides back by Scott et al. In the review article that is presented. The circumference of the limb, obviously, and then the arterial occlusion pressure of the limb that you are hoping to achieve. Okay, when we're talking about types of cuffs, there's a wide variety of tourniquets, inflatable cuffs, elastic knee wraps, etc. The narrow nylon cuffs are equal to 5 centimeter elastic cuffs at 50 millimeters of mercury, both at rest and exercise, according to previous studies. When we're talking about the widths of the cuffs, the legs are the ideal range that you want to get in is within 4.5 to 18.5 centimeters. The arms are obviously a little bit smaller just given their overall circumference measurements. And then wider cuffs, 13.5, really should be limited when it comes to the upper extremities due to the attenuation that occurs of the hypertrophy status right below the cuff. So obviously if you have a wider cuff, it's going to go further down the arm, and thus less motor fibers will be getting the benefit of BFR. Legs, you want a wider cuff. Some individuals did not reach arterial occlusion using narrow cuffs on legs at pressures even up to 300 millimeters of mercury. So I did have a colleague inquire as to whether he could use a TheraBand in order to perform BFR in his patients, in hopes of potentially being a little bit more practical and savvy rather than investing in some of the higher expensive cuffs that are out there. And so in order to actually answer his question, we need to look at a couple of variables, right? So the highest resistance band that I have had access to within clinical settings that I've worked at have been the black. And so let's say that we have a 1 foot strip or so of black TheraBand, and that we stretch it to 50%, and we use that as a BFR band. So the other variables that we need to consider are the circumference of the limb. Say, for example, it's 50 centimeters. And then if you actually took the surface area of the band, which is going to be important because that takes into account the width. So it would be 50 centimeters with 14 centimeters being the width of the band, which is within the allotted range as previously discussed. That would give you a surface area of 700 centimeters squared. And then you would need to divide, in order to get to the adequate pressures, you would divide, so make sure that we get everything into metric first, right? So we convert the 12.3 pounds to 5.5 kilograms and divide by the centimeter squared, giving us the equation, or the equation there seen in the grid, and that would allow for 0.00797 kilograms per centimeter squared per wrap or revolution of the TheraBand around the limb. All right, so how much pressure do we actually need in that unit, i.e. the kilograms per centimeter squared, right? So according to Lenicky, right, if it's a 50 centimeter limb, you need 120 millimeters of mercury, which equates to 0.163 kilograms per centimeter squared. You divide the TheraBand pressure per revolution by that target pressure, would give you number of revolutions 20. And so practicality of this is, I think, somewhat limited in the sense that getting a TheraBand long enough to go 20 times around a limb with 50% tension. Granted, you could, stretch the band further and get higher pressures, but I think that it is not the most ideal scenario in answer to the colleague's question. And then taking that all, if we look at the legality and legislation when we're talking about BFR scope of practice, as well as what items and or resources can be used. So BFR training scope of practice, APDA states that the BFR training is part of the professional scope of practice for physical therapists. They encourage therapists to check their state's practice acts, which may be silent in regards to the new form of training such as BFR, and then if that's the case, check state laws for confirmation. Here in California, the Practice Act is silent on BFR and no laws prohibit the use of BFRT, and thus it is legal here for therapists to implement. Okay, then if we're considering FDA regulation and pneumatic tourniquets, they are considered a class 1 under the FDA and are regulated products. Thus, it's important and essential to ensure that the product and or cuff that you're using for quote-unquote BFR is registered and approved by the FDA when practicing within the United States. Thus, further giving an example previously that a TheraBand may potentially leave you open to lawsuit if you're practicing in the U.S. So it's best to spend the money and ensure safety within the clinical setting. All right, so billing, so it's obviously billed under the standard physical therapy codes depending on the activity that you are performing with that said patient. Thus, if you're doing BFR and NMES, then it would be potentially neuro-re-ed, unless you're really considering that you're strengthening the muscle at that time point. But therapeutic activity, whether you're doing a manual technique with it, what have you. Again, it's billed under the traditional therapy. Okay, so beyond the legislation, right? So let's consider more clinical relevant information from patient to patient, such as rating of perceived exertion and the adaptation that it can occur with blood flow restriction training. So here's a study that gives you a decent idea of what potentially you can expect with your patients over time, right? So the first 2 sessions, relatively high, 7.5 out of 10 RPE, and this is comparable to the same slope that is seen with people acclimating to high intensity training, that by the 6th session there's a significant decrease in the rating of perceived exertion. So if they state that hey, this is actually really hard, tell them that's a normal sensation and that this should accommodate over several sessions. And again, you can see that the parameters that were used with this study, the traditional 4 sets, 30, 15, 15, 15, 20%, and 1 RM with right, related to one's RPE with exercise is their cardiovascular response, right? So subjects is a small study, right? So there's only 8 subjects here. They're in upright stationary cycle. They're doing it for 30 minutes with 40% VO2 max. The BFR was 20%, or I'm sorry, 200 millimeters of mercury, 50 millimeter wide, Katsu Master, Sato Sports Plaza cuff. There was no BFR on the control. And so what we can see here is that they compared the hemodynamics to the controls and the BFR at 10 minutes of exercise. And you can see that all those parameters highlighted in yellow show that there is a statistical significant difference with a p-value less than 0.01 for both heart rate, stroke volume. Again, stroke volume not being higher, but actually being lower for the BFR group. The ventilatory capacity, or liters per minute, is increased in the BFR, suggesting higher demand. The total peripheral resistance is also higher within the BFR group. Essentially, for any blood pressure reading, you can see that it is somewhat higher, or at least statistically, within the BFR group during the first 10 minutes. Slides we'll actually see what occurs from that 10-minute time point to the 30-minute time point. And what we can see here is that between the control and the BFR group, that that there was no statistical significant difference when it came to cardiac output, stroke volume, heart rate, VO2 max, or arterial VO2 difference. Start to see a difference, again, is still within the blood pressures. So between 10 and 30 minutes of exercising, there's no statistical significant difference in diastolic arterial pressures, total peripheral resistance. Statistical significance was seen with a decrease in systolic arterial pressures, a decrease in mean arterial pressures in the BFR group. The BFR group did say that they have higher RPE, which goes along with a higher blood lactate. So yes, though there is a higher level of systolic blood pressure and arterial pressures in the first 10 minutes, that when the body actually begins to accommodate to the additional stress, even within the same session, that the arterial pressures are below that of the arterial group, of the control group, excuse me. So conclusions of the study. So BFR, stroke volume versus heart rate, 0 to 10 minutes, stroke volume decreases, heart rate goes up. 10 to 30 minutes, no difference. BFR blood pressures, again, increase in systolic blood pressure, diastolic and mean arterial pressures, but then there's a gradual decrease in both the systolic and the mean arterial pressures due to the decrease in total peripheral resistance that occurs as the body adapts. BFR, blood lactate, and RPE increase gradually with exercise. Those go hand in hand and are expected, given the higher metabolic demand of the modality. Okay, same thing. I really want to drive home the cardiovascular response, given the fact that this is of highest concern for clinicians when performing blood flow restriction. So subjects, 23 years of age, 18 subjects. They're on a Velotron cycle ergometer, which you can see there to the right. Warm up 7 minutes, 30% VO2 max, so they were not going very hard. Intervals 3 rounds, 2 minutes work, 2 minutes rest, so 1-to-1 work to rest ratio. Cool downs 5 minutes. The low intensity was 40% VO2 max. And so there was 3 groups, as you can see denoted here. 80% arterial occlusion pressure was utilized, which was an average of 143 millimeters of mercury for the BFRs. And then the intensity was that they did the low intensity of 40% VO2 max, and their watts was also standardized with that. And you can see the high intensity was nearly double that. So the hemodynamics and see what actually occurred. So when you're looking at systolic, you can see that the red is denoted by the BFR group, and the black dots on the bottom show the low intensity, the grayish dots show the high intensity. You can see the BFR for systolic, regardless of whether in the interval or the rest, that it's well right in between both the low and the high intensity, thus suggesting that the systolic blood pressure is safe and obviously potentially effective with BFR. Okay, so this shows the diastolic, same idea. So it shows the working intervals as well as the rest intervals, and comparing the diastolic pressures of the 3 cohorts. You can see here that there is statistical significant difference in the diastolic blood pressure as it gradually increases for the BFR group with the later intervals. And then with the mean arterial pressure, this is also statistically significant, that there's increase in mean arterial pressure with the BFR low intensity cycling group relative to the other 2 cohorts. And so the conclusion of the study was that low intensity blood flow restriction interval cycling can increase metabolic and cardiovascular demands compared to low intensity cycling alone. This increase in mean arterial pressure with low intensity BFR trials leads to increased myocardial workload greater than high intensity. Use caution within a vascular compromised population. Hence, continue to screen your patients as suggested in the safety section previous. So, conclusion. So, when we're looking at the effectiveness of BFR, obviously it can increase muscle size and strength effects. Used when traditional high loads may be inappropriate or unattainable, such as the neurologically compromised, the postoperative patient, and even those with muscular disorders such as the polymyositis. The quantifiable muscular adaptations present quickly. Training greater than 6 weeks may offer greater returns in strength and hypertrophy adaptations. BFR training has applicability to a range of populations who may seek to progress strength with reduced loads on associated tissues, including muscles, tendons, connective tissue, and bones. And early studies indicate that BFR may be positive in effects on bone remodeling. When we're talking about the mechanisms behind BFR and why it actually induces the changes to the body that it does. You have the high intensity resistance training group that has higher mechanical tension, whereas the BFR low intensity group has lower mechanical tension but high metabolic stress. You can see that that affects the secondary mechanisms leading to the hypertrophy. Safety and side effects, again, follow the basic principles presented. Here are the 12 summary points that I wanted to get across. Confirm no contraindications. Hemodynamically unstable patients should not take part. Same with the thrombotic diseased patients or history thereof. Remind them of the potential hemorrhaging. Individualized training methods should be applied, not only for the intensity of the cuff, but also of the intensity of the exercise and the mode of the exercise. Build relationships and trust with your patients, which is standard across the board regardless of what intervention you're applying. Pay attention to fainting, dizziness, lightheadedness, etc. Do use caution with the older, bedridden, and the postoperative patients. Have an AED available. Stay within the intensity and duration loads as recommended. If someone's sick, consider not doing BFR. If unsure about medical conditions, seek specialist consult. All right, and then here, again, these are just reference slides for you. I'm not going to go through them in detail as we did previously, but by all means, utilize these evidence-based practices as presented by Scott et al. In 2014 for guidance when you're applying blood flow restriction training within your clinical setting. And then same when it comes to the type of exercise and the parameters, the workloads, the work volume, the rest intervals, etc. Even the frequency of training. Again, 2 to 3 times per week is the best recommended advice. Please feel free to leave questions, comments, feedbacks, and discussion points in the comment section below. Thank you so much for listening. If you would like to look over my references and or continue research on your own, flip through the slides.